Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Meet the Professor. As today we talk about the management of ovarian cancer with Dr. Stephanie Lheureux, who's the gynecology site lead and co-director of the Beyond Chemotherapy program at the Princess Margaret Cancer Center at the University of Toronto in Toronto. We have a great faculty for this series, and later on we'll show you the results of a survey we did of the faculty of their usual treatment practices. As always, if you have any questions or cases you'd like to run by Dr. Lheureux, just type them into the chat room, and we'll talk about as many of these as we have time. We also put a very quick pre- and post-meeting survey in there in the chat room. If you could please fill that out, it really helps us understand your needs and your interests. We know a lot of people end up listening to these webinars while they're driving in their car and, working out and raking the leaves. And if you're into audio programs, check out our Oncology Day podcast series, including a recent program with Dr. O'Malley going through ovarian papers from the SGO meeting. We do webinars all the time. Next week, we'll be continuing our series on HER2-positive breast cancer with Dr. Lynn from Dana-Farber. The next day, we'll be starting our multiple myeloma series with Dr. Sagar Lonial. And then on Monday, October the 10th, we continue our non-small cell lung cancer series specifically focused on patients with EGFR mutations, and we'll be working with Dr. Yanni again from Dana-Farber. Hopefully we'll be able to go to Orlando in 3 weeks, although gosh, what a horrible situation is occurring there and nearby to us in Miami. Fortunately, we escaped from the hurricane, but hopefully everyone gets through it there. But hopefully we'll be going to Orlando in a few weeks for our day-long annual meeting with Florida cancer specialists. We have 15 clinical investigators coming there. We're covering 20 different tumor types. If you're not in the Orlando area, you can check it out online. We have a great program set up for that on October the 22nd. But today we're here to talk about ovarian cancer. And as always, we have a bunch of cases from community-based docs, both gynecologic oncologists as well as medical oncologists. We'll go through those with Dr. Lheureux. We're going to start out going through one of the papers that Dr. Lheureux did I found so interesting. Then we'll jump into the cases. We'll go through the faculty survey. And if we have time, we'll check out some of the papers Dr. Lheureux has written. If you don't have time, you can check them out afterwards along with all the papers in the appendix. But Stephanie, I want to just talk about, I love it when you have graphics that really help understand the disease, particularly translational issues. And you had this great paper in the Seminars in Cancer Biology talking about the molecular, cellular, and systemic aspects of ovarian cancer and the microenvironment. So can you give us a little sort of primer or, kind of lesson on the translational issues with ovarian cancer that you got into with this paper?
Yeah, no, I think we talk about ovarian cancer, but ovarian cancer is a big box. And we know now that it's very important to differentiate the different subtype of ovarian cancer. And we know the most common one is high-grade serous ovarian cancer. And even now in high-grade serous ovarian cancer, we go deeper in characterizing high-grade serous ovarian cancer. And we know that high-grade serous ovarian cancer has TP53 mutation in almost all the cases. And now we know also that half of the high-grade serous ovarian cancer have this homologous repair deficiency that can be defined by different tests. And then now we go even deeper we knowing that the cell cycle status and the replication stress is important in high-grade serous ovarian cancer. We know also that they behave differently and they are usually diagnosed at advanced stage, despite that, they have some stick lesion and precursor lesion that can be there for 4 to 5 years. But what is interesting as well in high-grade serous ovarian cancer is that they have a specific microenvironment. And it's why we try immune therapy in ovarian cancer in high grade and not really being successful. And as you can see here, is because the microenvironment of high grade ovarian cancer is immune suppressive. And you have multiple elements that can participate to this immune suppressing microenvironment that we need to learn more to actually direct specific immune therapy. And then after you have all the other histology subtype with clear cell, low grade endometrioid, and mucinous that are very different and behave very differently. So it's why the pathology and understanding the biology is very important for ovarian cancer.
It's interesting here, you point out the difference in the microenvironment and ascites versus the omentum. What happens there?
So it's what is interesting is that, the ovarian cancer have this ability to to detach and to actually have little cell living alone in the ascites, and they usually regroup, and they have a very different microenvironment compared to the cell that actually are in the omentum. So when you look at the pathologies, high-grade serous ovarian cancer, but when you look at the microenvironment, there are very different microenvironment that they required to survive. And that is actually very important and also a challenge to actually better understand, because when we want to look at new treatment strategy, we need to have some preclinical model. And initially, our preclinical model was in vitro, in 2D culture, but we're trying to actually have new preclinical model to be more close to what happened in the patient. So we need to integrate the 3D, so we have all this organoid development, but also trying to see if we can mimic the microenvironment cell for the ovarian cancer. So that is something that is really interesting for further development.
We're going to talk later on about some trials. There have been attempts to bring in immunotherapy, the treatment of ovarian cancer. And in general, up to now, it hasn't been that helpful. It kind of reminds me of what we've seen, particularly with breast cancer. But what is it about the microenvironment, from your point of view, that immunotherapy, particularly checkpoint inhibitors, don't seem to work as well? Are these tumors not as hot as some of the other ones?
So it's why I think it's what the previous slide showed. It's actually, it's a very immunosuppressive microenvironment. As you can see, you have cancer fibroblasts, you have macrophage. So that is very immunosuppressive environment. And I think in ovarian cancer, PD-L1 may not be the key for treatment. So we may need to look at other potential target in the microenvironment. So I think it's something that is currently undergoing to look at potentially other antigen that we need to assess for ovarian cancer.
In terms of new agents or new strategies, what are some of the directions you think might be fruitful? We were chatting before, you mentioned something about stress, or maybe you can talk about that.
Yeah, I think, so for example, if we target about high-grade serous ovarian cancer, so when you look at about high-grade serous ovarian cancer, we know that DNA repair pathway is important. So, for example, the advancement with PARP inhibitor treatment in the high-grade serous ovarian cancer is a good example of understanding the biology that led to clinical application, because we have this concept of synthetic lethality. If you have this homologous repair deficiency and you block the PARP, you can actually have cell death. But then after, the homologous repair pathway and the DNA repair pathway is much more complex than this specific to target. So the DNA repair pathway is also linked with the cell cycle. So another target that is currently very important in terms of the drug development is how we can actually have this concept of synthetic lethality in terms of the cell cycle. What is a replication stress? And what is the status of the cell at that time? And is all this new development about ATR inhibitor, WEE1 inhibitor to try to target the cell cycle in high-grade serous ovarian cancer?
So we're about to jump into the pragmatics of taking care of these patients today, but one more sort of a biologic question. What has a lot of clinical implications is the issue of resistance to PARP inhibitors, particularly reversion mutations. How does that fit into this whole concept?
So that is actually a very interesting, and actually that is it's showing how adaptive ovarian cancer can be. So we know, because of the concept of synthetic lethality, that if you have BRCA mutation, you have this homologous repair deficiency. And if you block the PARP inhibitor treatment, you have the synthetic lethality because you can't repair, so the cell die. But so that is proven to be effective. But the problem is sometimes the cancer cell have this ability to reverse the BRCA mutation. So instead of being homologous repair deficiency because of the BRCA mutation, they reverse this mutation and be able to be homologous repair proficient again. So they can repair again. So they resist to the PARP inhibitor treatment. So that is all this mechanism of evolving of the cancer cell. And it's also possible that, there is some subclone that initially were not too many present, but with time evolution, you select this specific clone under treatment pressure. So that is also something that is possible. But definitely, the ovarian cancer cell have some specific mechanism of resistance to the platinum and to the PARP, which share some similarity because they target the homologous repair pathway.
So one more question from the chat room. Dr. McKenna wants to know, is there any potential future role of CDK inhibitors as cell cycle inhibitors? We know CDK has been combined with hormonal therapy, of course, but what about as cell cycle inhibitors? Does that fit into your model?
So definitely, I think what is very interesting for high-grade serous ovarian cancer is that they are all characterized by this TP53 mutation. So what that means is that they are really relying on this G2M checkpoint. So every target that can act on the G2M point, that could be a target. So it's through the WEE1 inhibitor, the ATR inhibitor, all of these new DDR agent can be a possibility because they act on the specific vulnerability of the high-grade serous ovarian cancer. So it's definitely something of interest. And there's a lot of trial currently looking at all this potential new drug.
All right, well, let's go make some rounds here. We have some really great cases. We're going to start out with a patient of Dr. Dana Chase, 55-year-old woman who has actually primary peritoneal cancer, HR proficient. Here are Dr. Chase's questions.
This patient had a primary peritoneal cancer. She did not have a pelvic mass. So I'm curious if people believe that in a primary peritoneal cancer, there's a role for primary surgical debulking. If there's no ovarian tumors and very little pelvic disease, is there a role for primary surgical debulking, or should we just automatically do neoadjuvant for the primary peritoneal types? And then I also was curious if people ever consider primary surgical debulking in the presence of pleural effusions. And then what do you do with these biomarker negative patients? Do you do bevacizumab maintenance, or do you do PARP inhibitor maintenance? I think we've had some recent data that make us a little more concerned about PARP inhibitor maintenance in the HRP patient population, but I wondered if that's changed anybody's practice.
So we'll get to that last question, which is a huge one that I certainly would like to be educated on. But just first, let's start out with some of the more straightforward questions. What about primary peritoneal cancer? First of all, her questions about debulking and generally how you approach it.
Yeah, no, I think it's a very good question because we know that, the goal of surgery for ovarian cancer is to have no residual disease. So I think, if we think that we can do complete debulking surgery, we start with primary debulking. But I must admit that it's true that in the primary peritoneal disease, it may be difficult actually to assess the extent. So actually what we do in our center, we always have a multidisciplinary conversation with the surgeon and the radiologist where we review everything and we really carefully the imaging to see if actually she's debulkable or not. Because I think it's always something that we look at if the surgeon, I'm a medical oncologist, so I can, I don't do surgery, but if the surgeon say that he can debulk, the decision is to go first for primary debulking surgery, but after a thorough review of the imaging and the scoring. But
so
we definitely need to wait. Yeah. Sorry,
No,
I was thinking that we may, the question of neoadjuvant and everything, it's still a remaining question. So I really hope that the trust study that has been conducted will actually give us more information about this question of neoadjuvant or not.
So she also put in a question, not so much about primary peritoneal, but just about ovarian cancer in general, which is the role of debulking surgery in patients with stage 4 disease, particularly with pleural effusions.
Yeah, so that is also a good question because, I think stage 4 should be very differentiated between stage 4A, which is a pleural effusion, versus stage 4B, which is, solid metastasis in the liver or in the lungs. So that is very different. So definitely for 4B, I think, we usually start with neoadjuvant chemotherapy. For the 4A, where it's just, and again, we may not necessarily have the proof that it could be sometimes reactive pleural effusion. The only way is to do, thoracentesis and have cytology to see if it's really a positive pleural effusion. But usually in our institution, it's not something that, always is a hard stop to say no primary debulking surgery if the surgeon thinks that they can attempt the residual disease after the primary debulking.
So her last question, I don't know if I'm the only one who's confused about all this, but I definitely feel pretty confused about it. So we've seen this has been the sort of the year or the summer of voluntary withdrawals of PARP inhibitors in late line setting. Can you talk a little bit about your take on that, and also what the Canadian and EU thoughts are, approach to this has been?
Yeah, no, I think has been an intense time. You're right, with all this withdrawal and some confusion around. I think these 3 withdrawal is actually only when PARP inhibitor was used as treatment. So this trial was actually when patients have relapsed, and we used the PARP inhibitor as treatment in this 3 study. So the confusion is because they say that maybe, PARP is not beneficial. It's why it created kind of a confusion. But I think it's important to repeat that PARP is active. PARP is active and give benefit, but it's important to use the PARP in the appropriate time and also in the right patient population. So the PARP inhibitor treatment, when it's used, for example, at the time of platinum resistant, and that was the data from REL4 with the start of withdrawal start with Ricaprib. It was the first one in June 10. It's because when they look at Ricaprib as treatment, this trial in REL4 include patients with platinum sensitive and platinum resistant. So actually this REL4 data was patient with relapse. They have included patients with platinum resistant and platinum sensitive, and patients were randomized between chemo versus Ricaprib. And the chemo, depending on the platinum sensitivity or not. So if you were platinum sensitive, patient received platinum-based chemo. If they were platinum resistant, they received weekly Taxol or another type of chemotherapy. And what they have seen is that it's true that in the intent population, the result is different if we look at each subgroup. So the benefit of PARP was not seen in the platinum resistant. But there were benefits in terms of PFS in the platinum sensitive, but not in the platinum resistant. And actually in the platinum resistant, what they have also observed is that patients who have a BRCA reversion do not benefit of PARP. And if you have a BRCA reversion, chemotherapy is better than PARP inhibitor treatment. So I think all these trial and all these results show that definitely there's a parallel between platinum resistant and platinum sensitive. So I think in our practice, if patient is platinum resistant, I think, yes, it's unlikely that the patient would benefit of a PARP inhibitor treatment because there's some cross-resistance mechanism. And we also now from this trial, and it's the same in the SOLO3 study with olaparib, when patients have a BRCA reversion, they do not benefit of a PARP inhibitor treatment. So I think the withdrawal of this PARP inhibitor should not, impact what we should now offer to our patient. We know now PARP inhibitor can be active, and I think the earlier is the better for the PARP inhibitor, specifically because what we discussed before, we avoid the mechanism of resistance, we avoid potential reversion mutations, so it's better to use it upfront if possible. But I think it's still a very good treatment as maintenance for patients who have a platinum-sensitive disease.
So, yeah, that is very helpful in understanding that. But there also the issue, I guess, that's lingering out there is the increase in mortality. We actually saw that we've been talking about this trial in myeloma, that you saw this with venetoclax because they were using it in people who don't have the marker that they later figured out. And to me, that's like giving PARP to somebody who's platinum resistant. You know it's not going to work. So the control, first of all, you're adding toxicity, and then the control group, maybe it will work. Yeah. So any thoughts about whether these agents actually increase the mortality, or you're just using it when it doesn't have benefit, you get toxicity, et cetera?
No, I think it's why ESMO update was actually very welcoming regarding data on overall survival in first line. At ESMO, in few weeks ago, there were the overall survival update on the PAOLA. So the PAOLA was patient who received carbotaxol bevacizumab versus carbotaxol bevacizumab plus the olaparib. And the overall survival was in favor of the olaparib arm in the group of HRD patients. Not in the HRP, but in the HRD population, definitely there's a benefit of PARP inhibitor maintenance. And we also have the update of the 7 years follow-up of SOLO-1. SOLO-1 was patients who have a BRCA1 or 2 mutation, and also, again, significantly benefit of the olaparib maintenance for this patient. And what is also very important in terms of toxicity, what you were talking about, is that we didn't see a significant increase in toxicity. Remember that in the first-line setting, the PARP inhibitor is a specific duration, right? So in the SOLO-1, the duration of olaparib was 2 years, and the benefit seems to maintain. So the data that was presented at ESMO in the SOLO-1 was very reassuring in terms of the long-term benefit and the long-term toxicity. So it's why, as I say, I think if you can use PARP inhibitor earlier is better, because I think it's where probably the benefits is the best. And again, based on the PAOLA study, it's true regarding a question as well, that the patient who have HRP proficient, it seemed that, we didn't see this benefit in terms of our survival, but definitely the patient who have BRCA mutation when HRD tumor benefit of a PARP maintenance first line.
So another big development this summer, of course, was the presentation of the Athena trial, now data with rucaparib. I want to get your take on that in the light of all the other trials that we have out there. But just first, a couple of questions from the chat room. Dr. Kumar wants to know, how do you test for BRCA reversion, or should it be tested at all? I'll add, can you test it with cell-free DNA? Is it even a practical thing to think about at this point?
Yeah, so I think it's actually a very good question, because I think now we have more and more data coming, and it was also a presentation at ASCO this year, populating, showing that yes, BRCA reversion can be observed sometimes, as high as 20%. And we begin to know that this patient will not benefit of a PARP inhibitor treatment. So that can be detected on the tumor, which is not necessarily easy, but also can be detecting on circulating tumor DNA. Yes, so that can be detected. It's not yet validated, though. It was only part of study and curative assessment, but definitely something that we may need to think, and we need again to validate, but it's something that seems to be feasible, but then after need to see how we can translate in practice, because that has been still exploratory and part of clinical trial.
And Dilip in the chat room is an interesting question. I've never heard anybody bring this up, but I think it's interesting. What happens if you get a CR with neoadjuvant chemotherapy? What does the surgeon do when they go in there? They just look around and close up?
So that it's actually a good sign for the patient, because it means that they are very sensitive to the platinum chemotherapy, which is actually show that this patient will probably benefit of a PARP inhibitor maintenance, because we know that, PARP sensitivity is probably correlated with a PARP inhibitor sensitivity as well. So that is actually a good sign. In our institution, we still, remove we do still a standard debulking surgery. And even if we don't see anything, we keep doing the debulking surgery as standard of care.
So Vinod, we have the best chat room anywhere, incidentally. We get the best questions from our chat room. Here's another great one from Vinod.
That's good.
Are BRCA reversion mutations seen with other cancers? Because, we have breast, we have pancreas, prostate. Do you see these reversion mutations there also?
Yes. Yeah, there is. And there was a very good meta-analysis paper that was published, I think, 1 year ago. And they included ovarian, but also breast cancer. So yes, this reversion mutation was observed in other disease type. And what is interesting is that not only with PARP inhibitor treatment, actually platinum-based chemotherapy can also induce BRCA reversion as well. But yes, definitely that can be seen with other disease type.
So Dr. Rudolph in the chat room is reminding me that the Miami Dolphin football team is playing her husband's favorite team, the Cincinnati Bengals, tonight. We know that Miami is going to beat Cincinnati, Dr. Rudolph, but so I'm sorry to tell your husband about that. Anyhow, yeah, the last webinar we did, we lost the speaker for a couple of minutes. I was talking about the Miami Dolphins. Anyhow, getting back to the Athena trial and rucaparib, when I first saw the data report, I was like, oh, great, that, substantiates everything we've been doing. Now we have another alternative. Of course, it wasn't quite that simple. The FDA came in and said they want to wait a while. But what is your take on the data? It looks very consistent with what we've seen before. I don't see anything that's not consistent. What's your take?
No, I think I agree. I think it's very consistent across trial. And again, we cannot compare because the population is slightly different in terms of how they select them. But I think we can see that definitely PARP inhibitor maintenance as a first line is beneficial, definitely for the BRCA patient. So there's no doubt the BRCA patient, when you have the update of the overall survival from SOLO-1 and Paola, I think definitely, I think that is consistent. A patient with a BRCA mutation should have this maintenance first line PARP. The HRD, I think, is also consistent. There's always this question about the HRP, which is true, it's a debate. I think it's probably the limitation of the test. But I think it's reassuring. They all go in the same direction. They are positive trial. And I think we need, and I can see, it's true that the FDA want to wait the overall survival is because all this current talk, but the fact that these trials are consistent and the fact that we now have the update of Paola and SOLO-1 in terms of overall survival, I think is very reassuring.
So again, more from the chat room. Do you think that, any thoughts about HIPEC in ovarian cancer, and specifically Gonzalo wants to know about HIPEC in patients with BRCA mutations? I guess in a way it kind of makes sense. Is there any data to either that or intraperitoneal works better with BRCA?
No, I think actually it's a very good question because I think it's true. Like biologically and scientifically makes sense. That completely makes sense given the mechanism of action. I think HIPEC is something that is very interesting. And I think it's something that is still under investigation. A trial is currently ongoing to really assess and confirm, what pilot data have been shown. So I think HIPEC is definitely something interesting. Is currently not in our standard of care for everyone. We still think that we wait the new the rate of the phase 3 that is currently ongoing for our patient.
So I guess showing Joyce Liu's slide with all the trials on it, and that included the Velia trial, got Kristen in the chat room to say, is veliparib ever going to be around, ever going to be used, or is it going forever?
So that is a good question. So I'm in Canada, so we do not have this indication. So I do not have as much experience with veliparib as a drug because we don't have this indication. But it's a good question. I think what we know is that usually when we combine the PARP with a platinum-based chemotherapy, there's some synergy in terms of toxicity as well. So it's why when we combine the other PARP with platinum, we have to decrease some dose to be feasible. It seems to not be the case with veliparib, but I think the trial also was positive. But also I think what confirmed that the benefit is really with the maintenance treatment. So really confirmed the current strategy. It was a positive trial, but I think it's really confirmed the strategy of maintenance as well.
So one more question, or some related some papers that you've done, and a lot of people have questions about the addition of PARP to checkpoint inhibitors. Here's a paper from ASCO looking at niraparib and with dostarlimab. These are one-arm studies. The Mediola study looking at olaparib plus durvalumab with or without bevacizumab. Any thoughts about whether PARP plus IO is heading anywhere?
So that is actually another very good question because I think we know that PARP for BRCA and HRD is beneficial. The question is what we would do for the HRP and how can we actually sensitize the patient who are not HRD. So yeah, one strategy can definitely be acting on the microenvironment and try to, as we discussed, to convert this tumor hot. I think we definitely need to see what the result of this study will bring. The Mediola trial, it's a small study, but very interesting, and pilot that are very interesting in terms of the triplet. The triplet seems to have some interest, and it was not only the immune therapy, was also combining with the bevacizumab, so targeting definitely the microenvironment. So the triplet was interesting. So I think it's more work is definitely needed in the microenvironment to see if immune therapy and the PARP alone will be sufficient. I think I'm not sure yet. I think I want to wait the data.
So we'll talk a little bit more about the use of PARP in patients with proficient, HR proficient tumors. But I just want to point out and get your thoughts on this trial that you did on the opinion trial. Look, when you think about niraparib, particularly in the primary maintenance setting, and now I guess rucaparib in the HR proficient setting. But now we're starting to see data about olaparib, and maybe not a huge surprise, in this same setting. This is the opinion study looking again at various HR positive, HR negative BRCA, et cetera. Any thoughts? Is it look like basically all these PARP inhibitors have activity to some extent against HRP? Is there any way to differentiate them? Does niraparib or rucaparib have greater activity? Any thoughts about that?
So I think here in the opinion, we were in the relapse setting. We were not in the first line. We were in the relapse setting where patients were not previously exposed to PARP inhibitor treatment. So I think this trial opinion did not have a control arm. So it's very difficult to completely conclude because the olaparib was offered to everyone who have response to platinum-based chemotherapy if they were not BRCA mutated. But we didn't have a control arm. So what this trial shows is that definitely seeing that the patient who have this HRD seems to have an improvement but it's difficult to say improvement because we don't have a control arm, but definitely there's potential benefit. And I think this study is important because we have also all this discussion about the NOVA, because the NOVA trial was the trial where it was, again, at the time of platinum-sensitive recurrence where patients were not previously exposed to the PARP and they got niraparib as maintenance after response to platinum-based chemotherapy. So definitely this trial, NOVA, also showed improvement of PFS, but there were some questions about the overall survival because, they were not sure about the overall survival data. The problem of NOVA is that overall survival was not a primary objective. So the data was not completely collected to have this overall survival. And so I think again, there was, it's how we designed the trial. So overall survival was not necessarily an objective as a primary objective. So it's why the data is very difficult to conclude. So the opinion trial actually also show that, it's for the patient who have an HRD tumor, it seems to have a benefit of the PARP maintenance, even at the time of platinum-sensitive recurrence. And again,
so
yeah, go ahead.
Go ahead.
No, so it's why
all
I
right,
think,
well, go ahead. Yeah, we're going on each other. All right, let's just go to another case anyhow. So this next case is really interesting. This is actually a patient with a germline BRCA mutation. She actually got treated with rucaparib as monotherapy, what we were talking about before, for relapse disease. I think it was in 2018, and actually had a response, and that lasted, and she did great. And after 3 years of therapy, he started to get a little bit nervous. He was here reading things about MDS and AML with PARP, brought that up to the patient, and they decided jointly to stop therapy. So after you hear this case, I would like to get your thoughts about how long do you continue PARP and what your take is on the risk of MDS. This is a very upsetting case to this doctor, I can tell you. Here's the case.
She's 74 years of age, stage 3C primary peritoneal cancer. Initially, she has BRCA2 mutation. She does have a family history. As a matter of fact, she has lost her mother, two of her sisters, to the same disease, either breast or ovarian. We put her on rucaparib 600 PO/BID, and we kept her on it from 2018 through 2021. And the PET-CT in question is shown where she's got a lymph node in the pelvis. In June of 2021, we counseled her about the risk of MDS, and we kind of hedged more towards discontinuing the rucaparib. And we counseled her and we stopped it. 6 months later, CA-125 goes up. She was older, heavier, poorer performance status, so we didn't offer her secondary debulking. Besides, she had responded so nicely to rucaparib in the past, so we decided we were just going to give her carboplatin and liposomal doxorubicin and then put her back on the rucaparib.
So any thoughts, and maybe you can update us on where we are right now with the risk of AML-MDS?
Yeah, no, I think it's something that, we need to be careful. And it's why I think it's why we need to continue to monitor the patient regularly, because it's a risk that can happen. So it's why it's important to continue to monitor the patient regularly. And again, as I say, when you use the PARP inhibitor in first line, it's a specific duration. And the risk of MDS AML was lower compared to when you look at the recurrence. Because at the recurrence time, it's true the update from the SOLO2 showed that the risk of MDS AML was around 8%. So it's high when you think about it. And again, in the platinum-sensitive recurrence, it's true, like the trial was designed as we continue the PARP maintenance as long as the patient have benefit. So we didn't have a specific time. And it's very difficult situation because we were used to think that if patient have a relapse, it's very difficult to cure. And if the patient is stable on the PARP, we have a kind of a dilemma in terms of potential benefit and potential risk. So I think it's true. I often consult with the patient. We don't know what is the right duration of olaparib or rucaparib or any drug in the maintenance setting. But at the if patient doing well and if they seems not to have toxicity, I continue the PARP inhibitor, knowing this risk. I really hope in the future we'll be able to try to identify the specific risk factor about the risk of MDS and AML. I really hope that we can identify specific patient and for this patient we can stop the PARP inhibitor before they develop this AMS MDS. But it's a very difficult and tricky situation because 8% can be significant. But given the trial was built as long as they have benefit, I think it's something that I will discuss with them how they feel. Sometimes after 5 or 6 years you can discuss, but you don't have a good tool to use to see the patient have macro result disease that we can't see on the current tool we have. So that is where we're missing some tool to guide patient treatment decision.
So we hear so much about patient involvement in decisions. Eric Weiner, the new president of ASCO, that's one of his main things. And this is a perfect scenario where it was great to get input from the patient. One of the first cases we presented in this series was a patient with ovarian cancer who ended up getting AML, and she never got a PARP inhibitor. She got a bunch of chemo. And, a lot of people bring up this 8% figure and will say, well, there's about a 10% risk of, AML MDS, which sounds terrible, except the control arm for that 8% was 4%. So,
Exactly. And it's why I present both sides to the patient, right? It's because sometimes we only present the risk, but the chemotherapy has a risk as well. And I think it's important when we discuss with the patient, yes, the risk of MDS exists, but it also exists with chemotherapy. And it's why it's very important to point out that it was not null in the control arm. Because actually, when we know from SOLO2, for example, we cannot forget that the SOLO2 have a benefit of overall survival. And if you control the cancer, longer, it's impacting probably the patient life. And if you are in the placebo, if they relapse, they may need more chemotherapy. So they also have this 4% risk of MDS and AML. So it's a risk that is true. It seems to be increased with the PARP inhibitor treatment, but it's why, it's important to discuss with the patient what is their preference. Knowing that we miss tool and we need to develop further tool to have some predictive marker. And that is a work currently ongoing. But I think it's a discussion with patient.
Yeah, and Dilip in the chat room brings up the issue of CHIP, which you hear talked a lot about. Just to continue this discussion, we go to another case. This is from Dr. Martins. This is a patient, again, with recurrent disease. who ended up on olaparib monotherapy and then actually was stopped and went on to other therapies and was found to be pancytopenic. And here's his question about this patient.
I've been treating her for about 4 or 5 years, and she's now progressing. About a year ago, she had the thrombocytopenia that progressed to pancytopenia. She now has moderately severe pancytopenia. Her white count tends to be about 2. Her ANC is usually around 1,000. Her platelet count is usually around 20 to 40. And this has persisted over a year since stopping therapy. So I wonder if they've seen prolonged pancytopenia from a PARP inhibitor. She's not had chemo in many years. I did a thing that I don't do very commonly. I actually did a bone marrow biopsy on her looking for possible myelodysplasia, and there was no signs of myelodysplasia. So we basically have unexplained pancytopenia for a year after stopping a PARP inhibitor. So now when this lady progresses and she's got a slowly enlarging node in her abdomen, I can't give her any chemo with her severe pancytopenia, and I don't know what to give her next. Basically, I need non-chemo options for BRCA positive patient who has pancytopenia. The other thing I did with her was, because it was an isolated node that was growing, I asked the radiation oncologist to radiate it, which they did.
Any thoughts?
No, I think I will definitely have done the same. If it's a localized recurrence, I think given the current status, I would definitely do a local treatment with radiation. I think it's really highlight the importance to have more data on for patient on PARP in the long term and follow up our patient. I think definitely I will have done the same. I would definitely have done the bone marrow biopsy. I will have consulted him to ensure that she don't have any deficit in vitamin B12, folate, just to ensure that there's no, and I will definitely be very careful with additional chemotherapy in this case.
Do you think this was related to the PARP inhibitor? Have you seen this, delayed pancytopenia like this, or you think it may be not related?
I think it's why it's important to do investigation and really have the heme consultant to ensure that there's no other cause for this pancytopenia. But I think it's possibly related. It's definitely possibly related. And again, it could be also related to the previous chemotherapies that she has. I will not exclude that is not related to PARP, no. I think it's possible.
Alex in the chat room wants to know, what about immunotherapy for a patient like this? Would that be worth considering?
So I think immunotherapy, I think it's a very interesting area of research, and I think I'm very happy we continue research. But I think the data we have in the classical PD-L1 inhibitor treatment, the data for recurrent high-grade serous ovarian cancer, we know that the treatment with PD-L1 inhibitor alone are not great response. So it's why we're trying to develop new treatment strategy with combination or vaccination and try to have new target of antigen for the immune, because the result of the PD-L1 therapy in recurrent high-grade serous ovarian cancer are a little bit disappointed. So I think, if the other things, again, it's a little bit thinking outside the box, but it's also, all the development that is currently ongoing with all the antibody drug conjugate is the hope that if we are more targeting and have this specific antigen on the cell surface, we can be more specific and less toxic. It's also all the goal of this new treatment development of the ADC, to try to be more targeted, more specific to the cancer cell and less toxic for the normal cell.
Actually, we're about to talk about ADCs, but thinking about it in a pancytopenic patient, maybe that would be an interesting idea, a trial of an ADC in terms of pancytopenia. Maybe you could get away with it with an ADC where maybe you couldn't with chemotherapy. All right, here's the next case, clear cell ovarian cancer. You have a couple of papers. You've studied this. Here's a case in real life, a 64-year-old woman who's a patient of Dr. Neil Morgenstein.
64-year-old, stage 3 clear cell of the ovary, presented to me after surgery and received 6 cycles of carboplatin and paclitaxel and bevacizumab, routine blood work and imaging studies. She was found to have an elevation in her tumor marker and new disease right around 6 months after the completion of her chemotherapy. Her HRD is negative. And then the question is, how do we treat clear cell carcinomas of the ovary? And what's the optimal treatment for platinum-resistant disease? Personally, I was thinking of pazotinib, but would be interested in any other recommendation. And then, is there a role for second-look surgery in patients? Is there ever a role for second-line HIPEC? And then something I'm very tempted to do in this woman, either on trial or off trial, is what is the role for immunotherapy in patients with clear cell carcinomas of the ovary?
So here are a couple papers you did. Multi-omics, uncovering different phases of clear cell cancer, and molecular subclassification of clear cell. Can you educate us a little bit about clear cell and comment on this case?
Yeah, no, so it's why we were saying that the biology defined the different. Initially, for ovarian cancer, the big box pathology was able to actually distinguish the 5 different subtypes. And now with the omic or the profiling, we even go deeper in the specific category. So if you look at the clear cell, and actually these papers show that even in the clear cell, it's a box of different subtype of clear cell ovarian cancer. And we have tend to say that clear cell ovarian cancer is relatively resistant to the platinum-based chemotherapy because they have a very different profiling. So usually clear cell ovarian cancer is characterized by IRD1A abnormality, PI3K pathway abnormality. So they have a very different profile. But what this paper shows is also that there's a small group of clear cell that can be TP53 mutated. And it's true sometimes when you do an extensive IHC on clear cell, you can see that there's some clear cell that have a P53 abnormal on IHC. And this small subgroup of patient of clear cell, based on this study that was presented, may behave a little bit differently and maybe a little bit more like high-grade serous ovarian cases. That was a retrospective study that definitely need to be confirmed in practice to see if they behave differently. Because definitely, I think clear cell ovarian cancer that are P53 wild type are relatively platinum resistant. So in this specific case, I think if a patient have a relapse of a clear cell ovarian cancer and have, a long period-free interval, and if we think that debulking surgery can be again at no result disease, I think it's definitely worthwhile to consider, given that they are known to be relatively resistant to standard chemotherapy. So I think, if secondary debulking surgery is feasible to no result disease, I think it's a good strategy to consider. And I think it's where we were talking about immune therapy. It's a very different setting in clear cell ovarian cancer. I think high-grade serous ovarian cancer, as we were discussing, PD-L1 inhibitor didn't show significant activity. But here, the clear cell ovarian cancer is definitely something that is of interest. And again, at ESMO, recently, there was this Peacock trial that was presented with pembrolizumab in clear cell ovarian cancer. Again, it's a small study and a pilot study, but the response rate with the pembrolizumab was around 25%. So some interest and definitely some new trial that are coming. So I definitely, for clear cell ovarian cancer, I would try to see if there's any trial that patient can be enrolled, because there's specific interest of the immune therapy that need to be confirmed at trial, but it's definitely something interest. And then there's another approach because they also have this IRD1A mutation. Targeting, the ATR pathway can also be of interest, but it's again a little bit more early in the development.
So actually, I want to present this next case of a 61-year-old woman. I think this is the first case that I can recall that we presented on this series for something I've always found interesting, which is bevacizumab monotherapy in ovarian cancer. Here's Dr. Gossain.
After some progression, I just started her on single-agent bevacizumab. That is because she also started to have some ascites.
Did she respond? Did her ascites get better?
She was requiring frequent paracentesis. She has not required paracentesis for a long duration while being on bevacizumab. She had multiple delays in bevacizumab because of her high blood pressure. At one time, she had significant proteinuria. I stopped. That resolved. We resumed the therapy, but right now she's off therapy. At one time, would you consider adding bevacizumab as a single agent? Would you have preferred that this was part of her initial chemotherapy and bevacizumab was continued as so-called maintenance? When you are running into side effects like uncontrolled hypertension, despite of patient being on multiple antihypertensive medications, how do you tackle that? especially when you are running out of treatment options. And in proteinuria, what's your threshold to stop or reintroduce bevacizumab in these patients?
So it kind of reminds me of the old days, except the old days were, less than 10 years ago when all we had to talk about in ovarian cancer was Bev and proteinuria, hypertension, et cetera. But here it is, helping a patient. You have a couple great papers also about angiogenesis and gynecologic cancers in this paper here, and with a lot of great diagrams to go through. And then this other paper specifically looking at the use of bevacizumab and systemic review and a meta-analysis. Any thoughts?
I think it's an interesting case, and I think it's true. I usually do not use bevacizumab alone, but I'm not surprised that this patient may have responded because when we actually look at the ascites, when we do paracentesis and look at the ascites, we know that usually ascites have a high level of EGF, which is actually the target of bevacizumab. So it's true that there's some reports saying that bevacizumab can definitely help to dry the ascites, but usually I use bevacizumab in combination with standard chemotherapy because we know that there can be some synergy, and based on the Aurelia study in the platinum-resistant, combining chemotherapy with bevacizumab improved the PFS and the response rate and can give benefit to the patient. So in the platinum-resistant setting, if possible, if no contraindication, I usually use bevacizumab in combination with chemotherapy. And recently at ASCO as well, this year I presented a trial where I was looking at the weekly paclitaxel and bevacizumab, and to be honest, I was a little bit surprised by the response and the PFS in this. This was a control group, the weekly paclitaxel and bevacizumab, and this control group actually had, a good median PFS. Again, we're talking about platinum-resistant high-grade serous ovarian cancer. So bevacizumab in combination with chemotherapy can provide some benefit. In terms of side effects, yes, definitely, I think need to be monitoring with the blood pressure and the proteinuria. Regarding the proteinuria, what is a steroid? I think, when the patient is at 1, I actually discuss with the patient and with a nephrologist. And sometimes, depending on the benefit and if there's any other comorbidity or any other side effects, sometimes I allow until 3, just, in terms of the discussion again with the patient and with the nephrologist to see if it's something that overweights the benefit of doing. So it's something that I monitor. If it's at 1, I'm making sure that I do a close surveillance. And then if it's 1 or 3, I actually, discuss the benefit and risk of continuing for this patient.
So speaking of platinum resistance, here's one of my favorite platinum-resistant cases. And speaking of paclitaxel, incidentally, you're talking about paclitaxel bevacizumab. How about paclitaxel tumor treating fields, which is what this patient got? This 69-year-old woman is a patient of Dr. Chase. Here's what happened.
She had a platinum-resistant recurrence and started on the clinical trial with Tumor Treating Fields and paclitaxel. She had 11 cycles, which was pretty amazing. So the question is, is this patient still platinum resistant? Is she a, more of like a platinum sensitive patient because she got such an amazing response? She has a great performance status. She swims every day. She's super active. I had 2 patients on this trial, and both of them did unbelievable.
Really?
Yeah. I like to put patients on platinum-resistant trials, but they both did amazing.
Did they have any objective evidence? I mean, they were getting paclitaxel, but did they have tumor markers go down or any shrinkage?
Yes, for sure. One of them had a complete response.
Wow.
Yep. Yeah. I mean, both of them maintained their performance status, maintained their, outside activities. I do think that it's going to require a lot of hand-holding.
So I don't know how much of this is the tumor treating fields and how much is the paclitaxel, or maybe it's the combination. We were talking about maybe the tumor treating fields resets the platinum sensitivity. I don't know. I never understood tumor treating fields anyhow. Any thoughts?
So I think it's a very interesting area because TTF field is actually a different way of delivering treatment. So I think, when we talk about all the treatments, so we give IV or PO, but it's very hard to actually know how much going really to the target in the cancer cell. So here is another way of drug delivery. And instead of doing IV or PO, is actually, it's local. So it's here through electric. So it's a very different way of delivering treatment. So I think it's a very interesting approach. And again, I think, combining the TT field with the weekly paclitaxel, you combine different approach of treatment. So yes, maybe, it was a combination. And again, the trial has been done and shows some interesting activity. And then now moving forward to the phase 3 where we wait the result. But definitely, I think it's something that is showing the importance of improving the drug delivery to the target. And I think it was very interesting as well. I really like a comment of, she received 11 cycles, so she's still platinum resistant. So I think that is actually something that happened a lot in our clinic as well, because the patient is in theory platinum resistant according to the definition. And then we put them on different clinical trial, different treatment. And sometimes I have as well, I'm wondering, and GCIG actually changed a little bit the criteria, which now we talk about platinum-free interval. And actually, sometimes when actually the platinum-free and I have multiple line of treatment, it's not uncommon that sometimes I will challenge with cisplatin, for example, a single agent to try to, have some benefit as well. So there's some paper, and again, small series studies showing that, after a long platinum-free interval, and when the patient didn't have platinum, maybe re-challenge with a platinum can be of interest. And the recent paper that was published as well say, maybe we can consider that at, when the platinum-free interval was 3 months, but didn't progress on it, but they have, So it's why this data of platinum resistant of 6 months is a kind of a theoretical threshold, but it's a continuous variable. So I think it's not something that I think it's something in practice that can be considered if appropriate.
So this is a great paper you did looking at the issue of platinum-resistant ovarian cancer. Fantastic graphic here going through all the different strategies that are being looked at in these patients. We talked before about antibody-drug conjugates. There's been a lot of attention to mirvetuximab. We've seen more and more data on that, kind of wondering when or if that's going to actually come into practice. There you have the issue that you see with a bunch of these ADCs with keratopathy, and we'll wait and see. But I want to ask you about this, and these are actually some posters that are actually being presented in the next couple of days in New York at the big IGCS meeting, looking at this agent, I guess the nickname is UPRI, a antibody-drug conjugate. And maybe you can talk a little bit about what we know about this, the marker, which is NAP12, in terms of that, upifitamab, rilsodotin, or like I said, UPRI. It looks like, as with mirvetuximab, the marker is stable. You can check out these in our slide set, looking at the measurements of the markers, the IHC concordance, but also where things are heading in terms of new trials. There's a more definitive monotherapy study that's being done, the UPLIFT study. And again, looking at monotherapy, but also the idea of combining it in platinum sensitive with carboplatin. So any thoughts about ADCs in general, both this agent and others, including mirvetuximab, and whether or not you see these moving into the platinum resistant space?
No, I think it's, as we discussed, it's an interesting area to try again to improve the drug delivery and to try to lower the toxicity to increase our therapeutic index. But again, here it's very important to have a highly selective monoclonal antibody to a specific tumor-associated antigen. So when we look about mirvetuximab, the antigen is a folate. When we talk about the other one is a NAP12. So it's a different antigen that is on the surface of the cancer cells. So it's why it's how we can use to select the patient. But again, as soon as we use an antigen, we need to define it in practice. So again, the expression, and we saw that actually with mirvetuximab, is not necessarily the percentage of expression, but maybe also the intensity. So it's something that, in practice, and how we assess this tumor antigen will be important, because it's a target of the ADC. And I think what is the promise is to be more specific, more targeting with less toxicity. But when we talk about ADC as well, we cannot forget about the cytotoxic payload. And where you say why we actually may be able to combine with chemotherapy because we are more specific, so decreasing the risk of side effects. So maybe we can combine with other type of chemotherapy. Because if the payload, for example, is a DM4, the target of the DM4 is the microtubule. So it makes sense to combine with a carboplatin, because it will be like a carboplatin taxol, but much more specific, much hopefully less toxic. So it's all this kind of promise. If we are ADC really specific to the tumor antigen, and we can probably combine with other medication.
We're seeing so many ADCs now in practice. Breast cancer, TDXD, and HER2 positive has really revolutionized the approach. But also some of these, including TDXD, you see chemo type side effects. I think these agents being looked at with ovarian cancer, I haven't heard about that. In general, what is the tolerance to these ADCs, for example, compared to conventional chemo?
So what we have seen is you can still see some fatigue. With some specific ADC, you have a specific ocular toxicity that can also be observed, and where you need some proactive measure. And you have seen also some elevation of the liver enzyme. That is a specific ADC mechanism. That is usually the toxicity that can be observed.
So I want to finish out with just a couple of results from our faculty survey. This is sort of our payola question, so to speak. We present a scenario where a patient presents with extensive intra-abdominal disease, gets neoadjuvant chemo bev, has a good response, goes to surgery with the R0 resection. And the question is, what kind of maintenance therapy would you use if the patient had a germline mutation? Most of the faculty, including you, say they go with a payola approach of olaparib. In what situations do you use this strategy?
So I think here the strategy is definitely she have a germline BRCA mutation, so she need a PARP maintenance. So that the PARP maintenance is something that we need to offer to her. The fact that she was starting on carbotaxol bevacizumab, I think the bevacizumab is not a gap maintenance; it's actually with chemotherapy and then continue as a maintenance. So because she was on the bevacizumab, I will continue bevacizumab based on the PAOLA data.
So here's really probably the most common question that we get, which is, of course, what do you do with primary maintenance in the patient who's BRCA wild-type HR proficient? And the faculty is split here between Bev and niraparib. You go with niraparib. What's your thought there?
So again, here it's a controversial cases. As I say, like bevacizumab is usually starting with chemotherapy and then maintenance. So here I didn't put the bevacizumab because the bevacizumab, as the trial that was built, is actually with chemotherapy, because we think that bevacizumab with chemotherapy can actually improve potentially the chemo delivery and everything. So the bevacizumab is not a pure maintenance; it's with chemotherapy. And because this patient was not starting with bevacizumab at the time of chemotherapy, I will not just had as a maintenance bevacizumab. But she finished chemotherapy, so she didn't have, so she finished the carbotaxol chemotherapy, and then is a question of discussion of maintenance treatment. She's HRP, so I think, here it's a gray zone. And because she's a HRP, I think it's again here a patient discussion. I think, we have definitely is a subgroup where they have less benefit, but there is some patient that benefit of a PARP inhibitor treatment. And it's where there is some limitation in terms of the test, where the test is a continuous variable as well. There's a cutoff that was thought for HRD. But it's where the discussion should happen with the patient to see, if given the benefit that we know as a median, she want to try or not. It's a discussion. It's not, there is no right or wrong answer regarding that.
So, Stephanie, thank you so much for joining us today. We learned so much from you today. Audience, thank you for attending, talking about breast cancer and HER2 positive disease. Come on back next Tuesday. We'll see what Dr. Lynn has to say about TDXD and also tucatinib. Of course, she's a leader in the treatment of brain mets, so we'll see what she has to say about her 2 positive brain mets. Be safe, stay well, and go Miami Dolphins against Cincinnati tonight, Dr. Rudolph. Have a great night.
Thanks
so much, Stephanie.
Thank you.